Hi folks, so in this talk we're going to look at diseases of the renal parenchyma. This is just a brief introduction, and after this I would urge you to read some of the articles on Schoology about the various diseases which we'll be covering. So let's start with our first case, a 7-year-old girl who presents to the emergency department with headaches and vomiting. She has recently been partially treated for impetigo due to insect bites. Her blood pressure is elevated. The rest of her vitals look relatively normal. This is her urinalysis, and you'll note that she has 3 pluses of blood in the urine, plus proteinuria, and microscopy reveals red blood cell casts and granular casts. So this is acute glomerulonephritis. Now for each of these conditions at this stage, I'd like you to pause the video and see how much you can remember about the pathophysiology of each disease, its clinical features, the investigations you might want to perform, and the treatment, if any. So you can pause the video now and see what you remember about acute glomerulonephritis. We'll start with the pathophysiology. So this is an immune disease, and the immune mechanism is a type 3 or antibody-antigen complex disease. These complexes tend to deposit in the glomerular basement membrane and cause thickening of the basement membrane, the mesangium, and the capillary endothelium. There are many causes for glomerulonephritis, but probably the most common is still post-streptococcal glomerulonephritis, caused by infection with group A beta hemolytic strep and affecting mostly children between the ages of 3 and 12 and older persons above the age of 60. However, other infectious agents such as staph, salmonella, and various viral pathogens can also cause glomerulonephritis. There are immune causes such as SLE, polyarthritis nodosa, Henoch-Schönlein purpura, and Goodpasture syndrome, and other immune diseases such as that are specific to the glomerulus, such as membranoproliferative glomerulonephritis and IgA glomerulonephritis. Many drugs can cause acute glomerulonephritis. Some of the more common drugs that lead to this condition are interferon alpha, hydralazine, and propylthiouracil. The key clinical features of nephritic syndrome are hematuria, hypertension, and uremia. These patients often also have some degree of edema, oliguria, and proteinuria, but the proteinuria is usually less than 3.5 grams per day. You'll see the significance of this when we get on to nephrotic syndrome. Investigations may include urinary investigations. We're looking for microscopic hematuria and the presence of red cell casts and granular casts are highly suggestive of glomerulonephritis. The blood picture shows uremia due to intrinsic renal failure, and the patients are often hyperkalemic and have a metabolic acidosis, both of which can be attributed to their renal failure. Here's the second case. A 54-year-old male diabetic patient who presents to the emergency department with swelling of the legs and shortness of breath. He has pitting edema to the mid-thighs, sacral edema, and ascites, and his echocardiograph shows a pericardial effusion. So again, stop the video and see if you can figure out what's going on here. The patient's urinalysis shows 3+ of proteins, small amount of blood, a normal bun to creatinine ratio, a normal bun and creatinine, with some hyponatremia and a normal potassium. So this, of course, is nephrotic syndrome. If you wish, you can stop the video and see what you can remember about the pathophysiology, clinical features, investigation, and treatment of nephrotic syndrome. So nephrotic syndrome may be primary due to autoimmune conditions affecting the glomerulus, such as minimal change glomerulonephritis, focal glomerulonephritis, or membranous glomerulonephritis. Or it may be secondary to systemic diseases such as diabetes, SLE, sickle cell disease, or amyloidosis. Infections, including viruses such as CMV, EBV, or the HIV virus, or chronic bacterial illnesses like tuberculosis or malaria. Actually, to be honest, malaria is a parasitic disease. Certain drugs and toxins can also cause nephrotic syndrome. Penicillamine, gold, and other heavy metals, including lithium, have been implicated. Nephrotic syndrome occurs due to damage of the endothelial surface layer, the glomerular basement membrane, or the podocytes of in Bowman's capsule. This leads to an increase in protein filtration, and when the amount of protein filtered exceeds the ability of the nephron to reabsorb it, then there is loss of protein in the urine, leading to proteinuria and hypoalbuminemia. The edema is due to Starling's forces. The loss of protein reduces the capillary osmotic pressure and thus reduces the ability of the capillary content to pull fluid back in from the interstitium, leading to edema. These patients have massive proteinuria, more than or equal to 3.5 grams per day, hypoalbuminemia with an albumin level of less than or equal to 30 grams per liter, and may also have edema, hypercholesterolemia, and hypercoagulopathy. Investigations would include urinalysis, which shows a large amount of protein, and a 24 urine hour collection to define the 24-hour loss of protein. Bloods would include a blood count, renal function, lipids, C-reactive protein, and imaging may help define the extent of renal damage at a macroscopic level. Treatment is generally supportive and treatment of the underlying disease. Complications have to be treated, such as thrombosis, infection, and hyperlipidemia. Moving on to our final case, a 28-year-old female with low-grade fever for 2 weeks, swelling of the feet and face, and arthralgia. She was prescribed non-steroidals and antibiotics for this, and she has noticed that her urine is dark and scant over the past week. The patient's venous gas shows a metabolic acidosis with a normal anion gap. Again, we look at her urinalysis. As you can see, the patient has a large amount of leukocytes in the urine, specifically with the microscopy showing leukocyte casts and eosinophiluria. When we look at her electrolytes, we see that she has a degree of intrinsic renal failure with high PER kalemia. You can pause the video and think about what this condition is. Oh, sorry. This ultrasound shows both kidneys, and as you can see, there's lots of corticomedullary differentiation and slight enlargement of the kidneys, suggesting renal parenchymal edema and inflammation. Okay, so now pause the video and think about what this might be. Okay, so this is interstitial nephritis. Again, you can pause the video and see if you can remember anything about the pathophysiology, clinical features, investigation or treatment of this condition. So interstitial nephritis is an acute inflammatory condition involving the renal interstitium and the tubules, though the glomeruli are usually spared. There are many causes, including infections, both bacterial and viral, antibiotics, non-steroidal anti-inflammatory tablets, and other drugs such as diuretics and allopurinol. The disease is characterized by renal failure with oliguria and hypertension, evidence of hypersensitivity such as a low-grade fever, rash, or eosinophilia. The classic triad that was used to describe interstitial nephritis originally, which is fever, rash, and arthralgia, is quite rare. Only 5% of patients have all these conditions. However, most patients have at least one of these three clinical features. The investigations would include urinalysis. Eosinophiluria is said to be highly diagnostic of interstitial nephritis, but hematuria is rare. Bloods would reveal acute renal failure, eosinophilia, and an elevation in acute reaction proteins such as ESR and CRP. So we've had a quick look at the diseases of the renal parenchyma. If you have any questions, you can bring them up in class. Today, we looked at interstitial renal disease, including acute glomerulonephritis, nephrotic syndrome, and interstitial nephritis. Thank you.